How to wean a critically ill patient in intensive care off the ventilator and the breathing tube. That's what we talk about today, step by step. My name is Patrik Hutzel from intensivecarehotline.com, where we instantly improve the lives for families of critically ill patients in intensive care so that you can make informed decisions, have peace of mind, control, power, influence, so that your loved one gets best care and treatment always, even if you're not a doctor or a nurse in intensive care. So today I want to answer this question that I get all the time from families in intensive care. How do you wean a critically ill patient off the ventilator and the breathing tube? And this is such an important topic because if you miss one step in this process, or if the intensive care team misses one step in this process, it could all go pear-shaped and your critically ill loved one could suffer greatly because of it, and you as a family will suffer from it consequently. So it is such an important topic because many families in ICU are told that their loved one can't come off the ventilator or will never come off the breathing tube. And from my experience as a critical care nurse for over 25 years in 3 different countries, where I worked as a nurse manager for over 5 years, and where I've been consulting and advocating for families in intensive care all over the world since 2013, I can tell you that there is a structured, evidence-based approach to ventilator weaning and the breathing tube. But unfortunately, it's not always followed in ICU because of sometimes staffing levels, sometimes simply complacency. Sometimes it's about controlling the narrative. Sometimes it's about bed management. Yes, you've heard me correctly. It's about bed management, finances. What you see is not always what you get when you have a loved one critically ill in intensive care. So let's look at the step-by-step process to wean a critically ill patient off the ventilator and the breathing tube. So number one, stabilize the underlying condition. So first and foremost, the root cause that leads to ventilation needs to be treated and stabilized. For example, if it's a pneumonia, sepsis, trauma, surgery, cardiac arrest, all need to be managed before safe weaning can even begin. Number two, assess readiness for weaning. Before removing the breathing tube, the ICU team must assess whether your loved one is ready. This includes checking oxygen levels, blood gases, chest X-ray, levels of consciousness, and whether they can initiate spontaneous breaths. This also includes, breathing muscles, right? For example, if someone has been ventilated and intubated for many days or sometimes even a number of weeks, they are rapidly deconditioning, and that's obviously not good, which means if they're rapidly deconditioning, they are wasting their muscles, and then it's going to be much harder to wean off the ventilator. Number three, daily spontaneous breathing trials, also known as SBTs. Evidence-based practice guidelines recommend daily trials to see if a patient can breathe without the ventilator full support. This is often done with minimal ventilator settings such as CPAP, pressure support to test endurance. Number four, weaning protocols and gradual reduction. The ventilator settings are gradually reduced to let the patient's respiratory muscles strengthen. This step-by-step approach avoids setbacks like re-intubation. So for example, if a patient is ventilated with a breathing rate of 15 breaths per minute that are automatically delivered by the ventilator, right? And they're getting, let's just say for simplicity, 500 mils per breath. You want to reduce that gradually. You want to reduce it down to 12 breaths per minute, then to 10 breaths per minute, and your loved one then needs to breathe spontaneously on top of that. And that's how you gradually can wean off the ventilator until your loved one can initiate every single breath with support from the ventilator. And once that support is down to minimal support on, CPAP or pressure support ventilation, or that's when you can extubate. That's assuming your loved one is awake. That's assuming your loved one has good arterial blood gases. That's assuming your loved one is strong enough to breathe independently. Number five, multidisciplinary support. Weaning isn't just about the lungs. ICU physiotherapists in the US, respiratory therapists, and critical care nurses play a critical role in mobilizing the patient, suctioning secretions, and maintaining airway clearance. And you've heard me correctly saying mobilizing the patient. So a lot of families in ICU think, oh, you can't mobilize a patient when they're on a ventilator. But nothing could be further from the truth, right? You can mobilize. A good ICU will always mobilize. And if they're not mobilizing, I argue they're not a good ICU. Of course, there are contraindications to mobilization when patients are on ventilation with a breathing tube, but the bottom line is most patients can actually be mobilized, assuming they don't have a head injury, assuming they don't have fractures, assuming they don't have an underlying condition that stops them from mobilizing. So ask for mobilization. Number 6, nutrition and strength building. Patients who are malnourished or weak would struggle to breathe independently. A feeding tube, nasogastric or PEG tube, may be necessary during the process to maintain energy levels. Do not rush into a PEG tube, but I do want to mention it here as an option. A nasogastric tube will do perfectly fine. Number 7, minimizing sedation. Sedation needs to be lightened or stopped so the patient is awake enough to breathe spontaneously and follows instructions. But also, not only sedation, also opiates need to be stopped, right, or lightened. Opiates are medications such as fentanyl, morphine, sedation, usually in ICU is midazolam or Versed, propofol, and Precedex/dexmedetomidine. The sooner you can get rid of all of them, the better. Let's look at common challenges in weaning from the ventilator. Number 1, ICU-acquired weakness from being bedridden and ventilated and sedated and being on opiates for too long, which leads to number 2, too much sedation and opiates delaying waking up and breathing drive. The more opiates you're giving, the less breathing drive there is. One of the main side effects of opiates such as morphine or fentanyl is reduced breathing drive, right? And that is really dangerous. You need to be aware of those issues. Number 3, secretions or infections like pneumonia that make weaning difficult. Number 4, underlying heart or lung disease, slowing the weaning process. These are common barriers, but they can be overcome with the right team, right protocols, and persistence. Advocacy is absolutely key. Many families in intensive care are told that their loved one will never come off the ventilator. In reality, families often aren't given the full picture of options such as prolonged weaning units, tracheostomy as a bridge for a safer long-term weaning, intensive care at home with tracheostomy and ventilator support at home. Go and check out intensivecareathome.com for more information. That's why here at intensivecarehotland.com, where we come in, we advocate for you and your family so you get the right information, the right care, and the best outcomes. And you can see what our clients say on our intensivecarehotland.com testimonial section and on our intensivecarehotland.com podcast section where we've done client interviews. So what's the conclusion? Weaning a critically ill patient off the ventilator and the breathing tube in ICU requires a systematic, evidence-based approach. It's not a guessing game. With proper protocols, a skilled ICU team, and strong family advocacy, many patients can be weaned successfully. If you want help with ventilator weaning for your loved one, go to intensivecarehotland.com, call us on one of the numbers on the top of our website. We offer one-on-one consulting and advocacy so that you can make informed decisions, have peace of mind, control, power, influence, making sure your loved one gets best care and treatment always. I have worked in critical care nursing for 25 years in 3 different countries, where I worked as a nurse manager for over 5 years in intensive care. And I've been consulting and advocating for families in intensive care since 2013 here at intensivecarehotland.com. And I can very, very, very confidently say that we have saved many lives with our consulting and advocacy because of our insights, and you can verify that on our testimonial section at intensivecarehotland.com, and you can verify it on our intensivecarehotland.com podcast section where we have done client interviews. And because our advice is absolutely life-changing, right? The biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And that's why we help you to improve your life instantly, making sure you make informed decisions, have peace of mind, control, power, and influence, making sure your loved one gets best care and treatment always. And that's why you can join a growing number of members and clients that we have helped over the years, saving their loved ones' lives. And that's why I do one-on-one consulting and advocacy over the phone, Zoom, WhatsApp, whichever medium works best for you. And I talk to you and your families directly. I handhold you through this once-in-a-lifetime situation that you simply cannot afford to get wrong. And when I talk to families directly, I also talk to doctors and nurses directly, asking all the questions that you haven't even considered asking, but must be asked when you have a loved one critically ill in intensive care. I also represent you in family meetings with intensive care teams. We also do medical record reviews in real time so that you can get a second opinion in real time. We also do medical record reviews after intensive care. So if in case you have unanswered questions, if you need closure or if you are suspecting medical negligence. We also have a membership for families of critically ill patients in intensive care. And you can become a member if you go to intensivecarehotline.com, if you click on the membership link, or if you go to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in a membership area and via email, and we answer all questions intensive care related. In the membership, you also have exclusive access to 21 ebooks and 21 videos that I've personally written and recorded. And all of that will help you to improve your life instantly, make informed decisions, have peace of mind, control, power, and influence, making sure your loved one gets best care and treatment always. And all of that you get at intensivecarehotline.com. Call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com with your questions. And if you like my videos, subscribe to my YouTube channel for regular updates for families in intensive care. Click the like button, click the notification bell, share the video with your friends and families, and comment below what you want to see next, what questions and insights you have from this video. I also do a weekly YouTube live where I answer your questions live on a show, and you will get notification from the YouTube live if you are a subscriber to my YouTube channel, or if you are a subscriber to my intensivecarehotline.com email newsletter at intensivecarehotline.com. Thank you so much for watching. This is Patrik Hutzel from intensivecarehotline.com, and I will talk to you in a few days. Take care for now.